if you break your arm and you go to the hospital, they take an X-ray and it shows that jagged white line across the bone.
Right. It's very clear cut.
Exactly. And there's a profound sense of comfort in that image, right? Because it's binary. The bone is broken or the bone is whole.
Yeah, it's just a mechanical failure. You can map it, pin it, cast it with like engineering precision.
But the moment you step out of the realm of bone and into the world of human soft tissue, I mean, physical trauma, lacerations, skin recovery.
Oh, that comforting precision completely vanishes.
It really does. Suddenly, that X-ray machine is basically useless. You are looking at a diagnostic landscape that is wet, constantly shifting, and just incredibly chaotic.
It is the absolute definition of diagnostic muddy waters. When we deal with soft tissue repair, we aren't just fixing a structural beam.
Right.
We're managing a live, microscopic battlefield. And we walk around every single day, completely taking for granted the staggering biological logistics required to, just manage this system.
Because we just view our skin as this passive wrapper,
Yeah.
right? Like it's just keeping our insides from falling out.
Yeah, which is a massive misconception.
And that misconception is exactly what we are dismantling today. We are taking a deep dive into the biological spacesuit that you are currently wearing.
I love that analogy.
Today's mission is to decode the complex science of skin integrity and wound healing. We're going to explore how your primary biological armor actually functions, what happens the millisecond it's breached, and the highly orchestrated construction project your body initiates to put itself back together.
And our foundation for this exploration is a stack of clinical nursing materials. We are analyzing an in-depth slide deck focused heavily on skin integrity and sensory perception.
Plus an audio lecture, right?
Yes, an audio lecture recorded for nursing students at Bevel State Community College. These materials aren't just, theoretical biology.
They're the literal training manuals.
Exactly. They are the practical field guides for the medical professionals standing on the front lines of tissue repair.
And by the time we finish this deep dive, your perception of your own body is going to change. Like a simple paper cut, a hospital bed, even a mundane scab.
You will never look at them the same way again.
You really won't. The sheer engineering behind our skin is staggering. But before we can even begin to understand how wounds heal, we have to establish what exactly is being wounded.
Right, you have to know what the armor is made of.
Because the primary goal in nursing, according to these sources, is simply to preserve skin integrity. I mean, the skin is the largest organ in the human body.
And it is carrying a massive physiological load. The workload is just relentless.
What is it actively doing, though, besides just sitting there?
Well, it's actively managing hydration levels, for one. It controls evaporation, so we don't just, desiccate like raisins.
Which is important.
Very. And it selectively absorbs certain topical substances while blocking others. But most importantly, it provides the physical tensile strength necessary to protect our internal organs.
The structural stuff.
Right, our vascular networks, our musculature. It protects all of that from blunt force and environmental pathogens.
So the sources break this armor down into a very specific layered architecture. And we really only need to focus on the top two layers for this discussion, right?
Yeah, the top two are where the main action is.
First is the epidermis. This is the outer shield. It's the literal physical barrier between your sterile internal organs and a highly hostile, bacteria-filled external world.
And the epidermis is fascinating because its outermost layer is composed entirely of dead cells.
Which is kind of gross to think about, but amazing.
It is. Your body basically pushes these cells to the surface, fills them with a tough protein called keratin, and then just lets them die.
To form like a protective scale armor.
Exactly, overlapping microscopic scale armor. And beneath that expendable shield is the dermis.
The structural foundation.
Right. This is where the heavy lifting happens. It houses the dense networks of collagen and elastin fibers that give skin its stretch and strength.
Along with the tiny blood vessels, the nerve endings, the sweat glands.
All the vital hardware.
I think of the dermis like the wiring and plumbing behind the drywall of a smart home security system.
That's a great way to picture it.
It doesn't just block intruders at the door, it manages the temperature, the fluid dynamics, and the sensory alerts for the entire house.
But any complex system has vulnerabilities, and clinical materials outline a myriad of factors that constantly threaten to compromise this biological armor.
Age is a massive one, right?
Oh, absolutely. The clinical data emphasizes that newborns, infants, and older adults are the most vulnerable populations.
Why newborns? I mean, their skin feels so perfect.
It looks perfect, but a newborn's skin is incredibly thin, and it hasn't fully developed its acid mantle yet.
The acid mantle. What's that?
It's a slight acidity on the skin's surface that deters bacteria. They don't have that shield yet. And then on the other end of the spectrum, as we age, the dermis loses its elasticity.
Right, the collagen production plummets.
Exactly. And the subcutaneous fat layer thins out, so older adult skin becomes incredibly fragile, almost parchment-like. It loses all those robust, self-regulating properties.
So age is a huge factor. Then we have to layer on internal physiological factors.
Mm-hmm.
The materials highlight diminished cognition or diminished sensation as severe threats to skin integrity.
Which makes sense when you think about it.
Right, because if a patient has neuropathy and cannot feel that a shoe is rubbing against their heel,
Or if they lack the cognitive awareness to shift their weight when a chair becomes uncomfortable.
the skin just takes the brunt of that sustained mechanical stress. It doesn't know to move.
Exactly. And circulation is another critical internal factor. The sources specifically differentiate between impaired arterial and venous circulation, and the distinction there is vital.
Oh, so what's the difference on the ground?
Well, arterial impairment means oxygen-rich blood cannot travel from the heart down to the tissue. The pipes are essentially clogged.
So the tissue is just starving.
Literally starving. It leads to pale, cool skin, and the wounds that form look punched out and very dry.
Wow. And venous impairment.
That is the opposite mechanical failure. The blood gets to the leg fine, but the valves and the veins fail, meaning the blood cannot flow back up to the heart.
So it just gets stuck down there.
Right. The fluid pools in the lower extremities, the pressure builds up in the veins until the blood plasma actually leaks out through the vessel walls into the surrounding tissue.
That sounds agonizing.
It's terrible. It literally drowns the skin cells from the inside out, causing massive swelling and these awful weeping ulcers.
Okay, so we have age, sensation, and circulation threatening the armor from the inside. But the external environment is just as hostile.
Oh, definitely.
The clinical term maceration comes up a lot in the text. This is when the skin becomes chronically waterlogged, right? From sweat or incontinence or improper wound dressings.
Yes. The tissue softens, it turns white, and it completely loses its structural integrity. It just tears away with almost no friction at all.
Like leaving a Band-Aid on too long in the pool, but on a massive scale.
Exactly like that. And maceration severely weakens the epidermis, making it susceptible to excoriation.
Which the texts define as the physical scraping or wearing away of the skin surface.
Right. And beyond those environmental factors, there are lifestyle choices. The texts list tanning, tattoos, and smoking as factors that degrade skin integrity.
I mean, smoking makes sense.
Yeah, smoking causes severe vasoconstriction, which literally chokes off the oxygen supply to those delicate dermal capillaries.
But the lifestyle factors section of the slide deck included something that really caught me off guard.
Oh, the botanicals.
Yes. Alongside smoking and tattoos, it explicitly lists herbal products. And it specifically calls out lavender and tea tree oil as threats to skin integrity.
It's a shock to a lot of people.
I see those two ingredients in almost every premium organic skincare product on the market. The marketing tells us they are deeply healing. So why on earth are they classified clinically as threats to the skin?
Well, the clinical perspective on botanicals strips away all that marketing. The body does not care if a compound is synthesized in a lab or extracted from a plant.
Right.
It only cares about the chemical's effect on cellular structure. And lavender and tea tree oils are highly concentrated, volatile, active compounds.
So they're just too strong.
If they are not heavily diluted and used with absolute precision, they act as potent chemical irritants.
They strip away the skin's natural lipid barrier.
They do. They dissolve the protective oils that keep the epidermis intact. It frequently leads to chemical burns or severe contact dermatitis.
Wow. So a breach in the armor is a breach, regardless of whether it was caused by a synthetic solvent or a quote-unquote natural botanical extract.
Exactly. The immune system reacts to the cellular damage identically in both cases.
Which brings us to the moment the security system actually fails. The armor is breached. How do medical professionals assess the damage?
That's where it gets highly analytical.
Because reading through these clinical materials, it becomes incredibly obvious that a wound is not just a wound.
Not at all.
The basic definition provided is simple enough. It's a, quote, disruption in the normal skin integrity. But from that starting point, clinicians use a highly detailed taxonomy to map the damage.
The categorization has to be precise because the entire treatment protocol hinges on the specific nature of the disruption.
So what's the first step?
The first assessment is the skin integrity status. Is the wound closed or open?
Okay, so a closed wound means the epidermal shield is physically intact, but the tissue underneath has been traumatized, like a contusion, right? A severe bruise.
Deep localized swelling, yeah. The blood vessels in the dermis have ruptured. They're bleeding into the tissue, but the surface hasn't actually broken.
And an open wound is where the physical barrier is actually compromised. So abrasions, lacerations, puncture wounds, and clean surgical incisions.
Correct. And once they determine it's open, they categorize the length of healing time. They divide injuries into acute and chronic wounds.
An acute wound has a short, predictable duration, right? It's a clean surgical cut or a scraped knee.
Yeah, the body's biological programming activates. It follows the standard timeline, and it repairs the damage.
But chronic wounds.
Chronic wounds represent a systemic failure of that biological programming. These injuries exceed the expected length of recovery. The healing process just stalls out entirely.
Like those pressure injuries or the arterial and venous stasis ulcers we discussed.
No.
And diabetic ulcers.
Exactly. Those wounds essentially get trapped in a biological feedback loop. They either remain in a state of constant destructive inflammation, or the patient's body simply lacks the vascular infrastructure to deliver the raw materials needed for repair.
I think about it like categorizing car damage. A superficial scratch across the door's paint job is an acute open wound. You sand it, paint it, and it's fixed.
Right.
But a chronic wound is like deep structural rust eating away at the chassis. You can paint over it all you want, but unless you address the systemic oxidation happening at the molecular level, the metal will never regain its integrity. It's an ongoing failure.
That is a spot-on analogy. And tracking with that, the clinicians also measure the depth. Is it superficial, just scraping the epidermis?
Or a partial thickness breach into the dermis.
Or is it a full thickness wound that destroys both layers and exposes the subcutaneous fat, muscle, or even bone underneath?
Right. Depth dictates how the body will have to rebuild. But the most immediate life-threatening concern for a clinician assessing a wound is the level of contamination.
Yes. The materials are incredibly specific here. They categorize the microbial threat into 4 distinct levels: clean, contaminated, and infected.
Now, the line between contaminated and infected always seemed blurry to me. If a wound is contaminated with bacteria, doesn't that just mean you have an infection? Why do the nursing materials treat them as completely separate diagnoses?
The separation comes down to the concept of the bacterial bioburden threshold and the host's immune response.
Okay, break that down for me.
So contaminated means that bacteria or other microorganisms have physically landed on the wound surface. They are present in the tissue bed.
But they aren't causing problems yet.
Right. They are simply colonizing the surface. They are not rapidly multiplying. And crucially, they are not provoking an inflammatory response from the patient's immune system.
So the bacteria are basically trespassing on the property, but they haven't tried to break down the front door of the cells yet.
Exactly that. But the moment those microorganisms begin to rapidly replicate, invade the healthy living tissue, and trigger the body's immune system to attack.
That's infection.
That is the clinical definition of infected. The body has recognized a hostile invasion and is fighting a systemic war.
And that changes everything about how a nurse handles it.
Completely. A nurse can use simple irrigation to wash away surface contamination, but an infected wound requires a massive escalation in treatment, often involving systemic intravenous antibiotics, because the bacteria have established a beachhead and are actively destroying tissue.
Okay, so once the clinicians have mapped the taxonomy of the wound, they know the depth, the contamination level, the vascular status, they step back, and the body's autonomous biological engineering takes over.
And this is the repair protocol. The logistics involved here are genuinely miraculous.
The texts outline 3 distinct, highly regulated stages of wound healing.
And the clock starts the literal millisecond the skin is compromised.
Wow, milliseconds.
Yeah. The first stage is the inflammatory phase, which typically lasts from the moment of injury up to about 3 to 6 days.
This is the emergency response and the biological cleanup crew.
Exactly. Blood vessels in the immediate area initially clamp down to stop the bleeding, but then they rapidly vasodilate, which means they open up wide.
And that vasodilation explains the classic symptoms of an injury, right?
Right.
The area gets red hot and swollen because the body is suddenly rushing massive volumes of blood plasma to the site.
Right. And that plasma is carrying white blood cells, specifically neutrophils and macrophages, which act as microscopic garbage disposals.
I love that image. Just cellular Roombas flooding the area.
Basically, yeah. They flood the wound bed, swallowing up dead tissue, foreign debris, and any bacteria that managed to cross the breached epidermis.
So what happens after the site is clean?
Once the macrophages have cleared the debris, they release chemical signals that trigger the second stage, which is the proliferative or regenerative phase.
How long does that last?
This runs from about day 3 up to roughly 24 days post-injury. The cleanup crew leaves and the construction crew arrives.
And they start building.
Right. The body initiates angiogenesis, which is the rapid sprouting of tiny new blood vessels to feed the starving tissue.
Because you can't build without a supply line.
Exactly. And simultaneously, cells called fibroblasts migrate into the wound and begin spinning a chaotic temporary web of collagen.
And this forms what clinicians call granulation tissue, right?
Yes, granulation tissue. It's the delicate, beefy red foundation of a healing wound.
And while that foundation is being poured, the epithelial cells on the intact edges of the wound begin to multiply. They migrate across the surface of that wet granulation tissue, slowly pulling the edges together.
It's essentially the body paving a new road over the repaired foundation.
But even when the skin is fully closed and the wound looks healed to the naked eye, the internal work is far from over. Because the final stage is the maturation or remodeling phase.
And this phase is often overlooked by patients, but it is critical. It can last from 21 days all the way up to a full year, or even longer for severe trauma.
A full year.
Easily. The initial collagen web laid down during the proliferative phase is fast, but it's weak and disorganized.
So the body has to upgrade it.
Exactly. During maturation, the body actively dissolves that temporary collagen and replaces it with thicker, highly organized, cross-linked collagen fibers.
The tissue is essentially stress testing itself, reorganizing the architecture to maximize tensile strength.
But, and the clinical texts note this, a scar will never regain 100% of the original skin's strength. At best, it peaks at about 80%.
The new tissue is a patch, not a perfect replacement.
Right.
Now, how a wound physically moves through those 3 cellular stages depends entirely on the architecture of the gap that needs to be closed. And the texts detail 3 distinct types of wound healing.
The first is primary intention, or first intention healing. This is the best case scenario.
When does this happen?
Primary intention occurs when the tissue loss is minimal and the wound edges are clean and easily approximated, which just means they can be brought perfectly together.
Like a surgical incision closed with sutures.
Exactly. The inflammatory phase is short, the amount of granulation tissue needed to fill the gap is tiny, and the resulting scar is just a thin hairline mark.
It's like taking a cleanly broken vase and applying a thin layer of superglue to the edges. You press them together, the bond sets perfectly, and the structural integrity is almost entirely restored.
Yeah, that's exactly it. But in severe trauma or massive pressure injuries, you simply cannot pull the skin edges together without tearing the tissue.
And that requires secondary intention healing.
Which is a grueling biological process. Because the gap is too wide to close, the wound is forced to heal completely from the inside out.
No.
The body has to generate massive amounts of granulation tissue at the base of the wound bed, slowly building upward, millimeter by millimeter, until the tissue finally reaches the surface level where the epithelial cells can crawl across it.
It's the biological equivalent of filling a massive pothole in a city street. You can't just throw asphalt over a deep hole. It will collapse.
No, it wouldn't hold.
You have to fill it with gravel from the very bottom, pack it down, add another layer, and repeat the process until you finally reach street level.
And secondary intention takes exponentially longer. It carries a massive risk of infection because the internal tissue is exposed for weeks, and it results in severe contractive scarring.
So that's primary and secondary. The third type detailed in the sources is tertiary healing, also known as delayed primary closure. And honestly, this approach sounds terrifying to a patient.
It does sound counterintuitive.
This is a scenario where a surgeon intentionally leaves a deep traumatic wound completely open. They do not suture it closed. The intuitive reaction is panic. If you have a massive abdominal surgical wound, leaving it gaping open seems like medical malpractice. Why would a surgeon purposefully expose a patient's internal tissue to the air?
The clinical logic is based on managing catastrophic internal pressure and infection. If a wound is heavily contaminated with bacteria, or if the tissue is suffering from massive edema, which is severe localized swelling,
Right.
suturing that wound closed is incredibly dangerous. The immune system is going to flood that area with fluids and white blood cells to fight the contamination.
And if the wound is sewn shut, that inflammatory fluid has nowhere to go.
Exactly.
The analogy that makes this click for me is a house fire. Closing an infected, swollen wound is like realizing a fire is raging inside your house, and your solution is to board up the windows and bolt the doors.
You're just building a bomb at that point.
You trap the heat, the smoke, and the pressure inside until the entire structure explodes.
The body desperately requires an exit route for the cellular battle casualties. The swelling needs space to expand, the pus needs to drain, and the dead bacteria need to be flushed out.
So the surgeon covers the open wound with sterile dressings and just waits.
They allow the inflammation to peak and resolve. Only after the wound bed is clinically clean, the bacterial load is neutralized, and the swelling has subsided.
Then they close it.
Right. Then the surgeon brings the patient back to the operating room to formally suture the edges together.
And when it comes time to actually close these breaches, the medical toolkit has evolved significantly. The sources mention the standard adhesive strips, heavy-duty sutures, and surgical staples.
They also highlight surgical glue for clean, low-tension lacerations.
But for massive trauma, they rely on skin grafts,
Right.
shaving thin layers of healthy skin from a donor site.
Yes, grafts and complex structural flaps that move muscle, fat, and skin while keeping the original blood supply intact. They even utilize HBOT, hyperbaric oxygen therapy.
Which is wild. HBOT is a fascinating application of physics to biology.
It really is. Patients are placed in a pressurized chamber, breathing 100% pure oxygen.
And the atmospheric pressure physically forces the oxygen molecules to dissolve directly into the blood plasma, completely bypassing the red blood cells entirely.
It delivers a massive payload of oxygen to deep chronic wounds that have lost their capillary networks, literally breathing life back into starving cells.
But regardless of whether a surgeon uses delicate sutures or a high-tech hyperbaric chamber, you cannot build a strong structure without the proper raw material.
No, you can't.
And you absolutely cannot build new tissue on top of a biological garbage dump. Which brings us to the logistics of supplying the construction crew and clearing the site.
The texts make it abundantly clear that hydration and nutrition are not just general wellness tips. They are non-negotiable medical requirements for wound closure.
Because the cellular demand during the proliferative phase is just staggering.
The body requires approximately 2,500 milliliters of water daily just to maintain the fluid volume necessary to transport white blood cells and flush away cellular debris.
And the metabolic rate skyrockets too, right?
Oh, massively. The sources state the total caloric intake must increase to between 20 and 35 kilocalories per kilogram of body weight per day, simply to fuel the cellular division.
And the hospital dietitians aren't just pushing empty calories either. The interdisciplinary care team focuses intensely on specific macronutrients and micronutrients.
Protein is the obvious requirement, as it provides the amino acids necessary to build new muscle and skin tissue.
But the materials specifically isolate vitamin A, vitamin C, and zinc as vital components of the repair protocol.
And their inclusion is based strictly on molecular biology. Without sufficient vitamin C and zinc, the human body is physiologically incapable of synthesizing collagen.
Wait, really? It just stops?
It halts completely. Vitamin C acts as a mandatory cofactor in the hydroxylation of procollagen. Without it, the collagen chains cannot twist together into a strong triple helix structure.
So you could feed a patient massive amounts of high-quality protein.
But without vitamin C and zinc acting as the molecular binders, the wound will stubbornly refuse to close. The bricks are piled at the construction site, but the mortar simply will not set.
And the care team doesn't just guess if the patient is absorbing these nutrients. They rely on hard data from the lab to track the raw materials in the blood.
Right, they monitor prealbumin and albumin levels.
Prealbumin has a very short half-life, so tracking it, aiming to keep it between 15 and 36 milligrams per deciliter, gives clinicians a real-time snapshot of the patient's protein status over the last 48 hours.
And overall albumin, which needs to stay above 3.5 grams per deciliter, provides a broader picture of long-term nutritional health.
They also run complete blood counts to monitor the white blood cell army and basic metabolic panels to ensure the kidneys are filtering out the waste.
However, delivering the perfect balance of nutrients is totally useless if the wound bed is covered in dead tissue.
Right, because before the body can lay down a single strand of new collagen, the site must be thoroughly cleared. And this biological excavation process is called debridement.
The audio lecture from Bevel State Community College breaks down several distinct methods of debridement. The most conservative approach is autolytic debridement.
Autolytic debridement sounds almost passive. The nurse supplies specialized moisture-retaining dressings over the wound and essentially seals it up.
Yeah.
But underneath that dressing, the body's own endogenous enzymes and macrophages are going to work. slowly digesting and liquefying the dead necrotic tissue.
It harnesses the body's natural processes, but it is incredibly slow.
So what happens when speed is required?
Then, clinicians move to enzymatic debridement. They apply prescription ointments containing concentrated chemical enzymes that actively eat away the dead protein structures.
And the most aggressive approach is sharp or surgical debridement, where a physician uses a scalpel or scissors to manually cut away the dead tissue until they hit bleeding, healthy margins.
But the method that dominated the audio lecture, however, was mechanical debridement, specifically the use of wet-to-dry dressings.
The instructor details the protocol. A nurse takes sterile gauze, soaks it in saline, packs it deeply into the crevices of the wound, and then just leaves it alone until it dries out completely.
And once it is bone dry, the nurse physically pulls the gauze out.
It is an older, highly mechanical technique, and it sounds rough.
It is brutal.
Yeah.
As the wet gauze dries, the woven cotton fibers shrink and heavily entangle with the dead necrotic tissue in the wound bed.
So when the nurse forcefully removes that dried dressing,
They are physically tearing the dead tissue out of the wound.
the lecture explicitly contrasts this with wet-to-wet dressings, which are kept constantly moist to encourage epithelialization, right? The delicate migration of new skin cells. Wet to dry is a demolition tactic.
It absolutely is.
And this brings me to a very stark, bolded instruction in the slide deck. It mandates that nurses must administer pain medication exactly 30 minutes prior to performing a wet-to-dry dressing change.
That 30-minute window is not a suggestion.
The specificity of that highlights the brutality of the procedure.
The physiological reality of a wet-to-dry dressing change is severe. The drying gauze does not perfectly differentiate between dead tissue and living tissue. It binds to everything.
Oh, God.
So removing it applies massive mechanical shear force. It's essentially ripping microscopic Velcro off a raw, highly vascularized, and exposed nerve bed.
The pain must be agonizing.
It is. Administering oral analgesics exactly 30 minutes prior ensures the medication reaches peak concentration in the patient's central nervous system at the precise second the nurse begins to manipulate the dressing.
The logistics of physically cleaning these wounds are bound by rigid clinical rules to prevent catastrophe, too.
Very rigid rules.
The slide deck emphasizes that a nurse must always clean from the least contaminated area outward to the most contaminated area, meaning they start at the center of the clean surgical incision and wipe outward toward the surrounding intact skin.
Right, you never want to drag bacteria in.
They also must use isotonic solutions, like normal saline, to prevent shocking the exposed cells with osmotic pressure.
And they are forbidden from crossing the wound more than once with the same swab, which, again, prevents dragging bacteria from the outer edges back into the sterile center.
And there is a strict prohibition against using standard cotton balls, which surprised me.
The cotton ball rule is a perfect example of microscopic tissue management. Standard cotton balls shed thousands of microscopic fibers.
And if left in a wound bed,
The body's macrophages attempt to consume the fibers but find them indigestible. The immune system responds by walling the fibers off, creating foreign body granulomas.
so these microscopic capsules of trapped fibers trigger chronic, localized inflammation that entirely stalls the healing process.
Exactly, you're accidentally planting tiny inflammatory bombs in the wound.
While the care team is managing the moisture, nutrition, and the debridement, they're also constantly analyzing the visual data the wound is providing,
They have to decode the damage in real time.
reading the wound bed like a living topographical map.
And the primary diagnostic tool is color. The clinical materials teach a universal traffic light system for tissue assessment.
Red, yellow, green.
Red, yellow, black, actually. If the wound bed is red, that indicates the presence of healthy granulation tissue. The angiogenesis has succeeded. The area is highly vascularized and actively building.
So red means proceed, protect the tissue, and keep it moist.
Yes. But if the wound bed is yellow, the caution lights are flashing.
Yellow tissue indicates the presence of SLU.
SLU is a stringy, viscous mass of dead white blood cells, fibrinous tissue, and cellular debris. It means the inflammatory phase is leaving behind too much garbage, and potentially an infection is brewing.
So that yellow layer must be cleared away before new tissue can grow.
And the final color is black, representing Escher.
Escher is deeply necrotic, completely dead tissue. It often looks like a thick, black, leathery scab covering the entire wound.
Now, what would be your instinct if you saw that on a patient?
My instinct, and I think most people's instinct, would be to leave a thick black scab alone to protect the wound underneath. It feels like a natural Band-Aid.
Leaving Escher in place in a clinical setting is a dangerous miscalculation. Because Escher is completely dead, it possesses zero blood supply. And without a blood supply, the body cannot deliver white blood cells and intravenous antibiotics cannot reach the area.
It acts as a biological bunker.
Exactly. Bacteria absolutely thrive in the dark, warm, moist environment underneath that dead leather, completely shielded from the patient's immune system.
Wow.
Furthermore, the sheer physical density of the Escher creates an impenetrable ceiling that blocks any new granulation tissue from growing upward. It must be aggressively debrided for healing to resume.
Alongside decoding the color of the tissue, nurses are meticulously mapping the physical geography of the breach. They measure the precise length from head to toe, the width from side to side, and use sterile probes to measure the depth.
But the most vivid concept in the materials is how they map internal damage that is invisible from the surface.
Right. The texts describe a technique for documenting tunneling and undermining using a standard clock face.
It provides a universal, standardized reference point for any doctor or nurse reviewing the chart. The patient's head is always designated as 12 o'clock, and their feet are 6 o'clock.
So a nurse might insert a probe into what looks like a small puncture wound, only to find that the tissue underneath the skin has completely dissolved.
Yes, the surface hole is deceiving.
And they chart it by saying, we have a 3-centimeter tunnel extending at 4 o'clock and undermining along the edge from 9 o'clock to 11 o'clock.
They are practically spelunking, mapping invisible cave systems carved into the subcutaneous fat by bacteria and pressure.
While mapping the structural damage, the clinician also analyzes the exudate. Exudate is the technical term for wound drainage, right?
Right, and just as the tissue color dictates the status of the wound bed, the color and consistency of the liquid seeping from the wound tell a complex story about capillary permeability and infectious load.
The texts categorize 5 specific types of exudate. First is serous drainage. This is clear, watery fluid.
It is essentially normal blood plasma that has leaked out of the capillaries due to the vasodilation of the inflammatory phase. It's a healthy sign.
Second is serosanguineous. This fluid is pink and slightly watery. It's serous fluid mixed with a small number of red blood cells, which is incredibly common in the first 48 hours after surgery as the microcapillaries repair themselves.
Third is sanguineous drainage. This is frank, visible blood.
And clinicians pay close attention to the color here, right?
Absolutely. Fresh, bright red blood indicates active, ongoing damage to an artery or vein, while darker red-brown blood usually means older blood that was trapped in the wound is finally draining out.
But the appearance of the final 2 types of exudate signals immediate danger. Purulent drainage is pus,
It is thick, opaque, and often carries a yellow, green, or brown tint.
and purulent drainage unequivocally indicates an active bacterial infection.
The fluid is just a toxic slurry of liquefied dead bacteria, destroyed host tissue, and exhausted white blood cells.
And the 5th type is purosanguineous drainage, which is a lethal mixture of pus and blood.
That indicates that the infection is so aggressive it is actively dissolving the newly formed blood vessels in the wound bed.
The nursing staff must meticulously document the volume of this drainage, noting if it's absent, light, moderate, or heavy. They sometimes even weigh the soiled dressings to calculate exact fluid loss.
They also document the odor. Is it faint or is it a strong, foul stench?
The presence of a foul odor, even if the wound looks clean, is a massive red flag, indicating the colonization of anaerobic bacteria deep within the tissue.
The rigorous monitoring of exudate, odor, and color serves one primary purpose: early detection of catastrophic failure.
We have mapped the ideal cellular repair protocol, but the clinical materials dedicate extensive sections to what happens when that protocol fails.
The complication section reads like a list of biological nightmare scenarios.
The most common, obviously, is infection. The texts differentiate between local symptoms, the swelling, the localized heat, and the purulent drainage we just discussed, and systemic symptoms.
If the local barrier fails, the bacteria enter the bloodstream, triggering systemic sepsis. This is characterized by soaring fevers, plummeting blood pressure, and full-body physiological distress.
Another acute complication is hemorrhage. Uncontrolled bleeding can be external and obvious, soaking through dressings in minutes.
However, internal hemorrhage is far more insidious. Blood can pool massively beneath the sutured skin or deep within an organ space, forming a hematoma.
And the sheer physical pressure of a growing hematoma can crush adjacent blood vessels, causing surrounding healthy tissue to suffocate and die.
Then we encounter the mechanical failures of the wound closure itself. The first is dehiscence.
It's a term that carries a visceral weight. Dehiscence occurs when a wound, typically a deep abdominal surgical incision that has been securely sutured, suddenly bursts open along the suture line.
The mechanical stress of violent cough, vomiting, or sudden movement overwhelms the tensile strength of the new collagen, and the biological glue fails entirely.
Dehiscence is terrifying, but evisceration is a true, immediate surgical emergency.
The visceration occurs when a wound forcefully dehisces, and the internal organs, most commonly the loops of the intestines, actually protrude through the broken abdominal wall and out of the body.
The nursing protocol for that is incredibly rigid, right?
Instantly cover the exposed organs with thick, sterile towels, absolutely soaked in warm saline to prevent the tissue from drying out and dying, and rush the patient back to the operating room.
There is one complication detailed in the Bevel State audio lecture that feels like it belongs in a science fiction horror movie. The instructor spends significant time discussing fistulas.
Oh, fistulas are wild.
The lecture defines a fistula as an, quote, abnormal halfway connection from one body part to another. The slide deck includes a harrowing diagram of a fistula forming directly between a patient's bladder and their vagina.
It's shocking to see.
The biological mechanics of this are just astounding. How does the human body accidentally construct a tunnel connecting two entirely separate organ systems?
The pathology of a fistula is a masterclass in the destructive power of the path of least resistance. It stems from the exact pressure dynamics we discussed earlier regarding tertiary healing.
The house fire analogy.
Yes. When severe infection, surgical trauma, or chronic inflammation causes tissue to break down deep inside the body, fluid rapidly accumulates. The body's immune response generates massive amounts of pus and inflammatory fluid,
Which is highly acidic and packed with tissue-dissolving enzymes released by dying white blood cells.
Exactly. And the fluid is trapped, the pressure is building, and those enzymes are desperately looking for an exit.
So if that pressurized enzymatic fluid is trapped near an adjacent hollow organ, such as the bowel, the bladder, or the vaginal canal, the fluid begins to dissolve the fascial plane, separating them.
It literally burns a microscopic hole through the walls of both structures to relieve the pressure. It forces a catastrophic biological shortcut.
Suddenly, fluid that must remain strictly contained in one system flows freely into another.
In the bladder to vagina example, acidic urine bypasses the urethra entirely, causing massive secondary infections and severe tissue degradation.
The mechanical logic is undeniably brilliant. The body prioritizes immediate pressure relief over structural integrity. But the result is devastating.
And it really is. The body sacrifices its own architecture to vent the pressure. It's a grim, fascinating mechanism.
Now, up to this point, our deep dive has focused heavily on acute trauma, surgical incisions, accidents, violent ruptures.
But the clinical sources reveal a disturbing truth.
Right, some of the most dangerous, insidious wounds a medical professional will ever treat do not come from a scalpel or a traumatic impact. They manifest simply from a patient lying perfectly still.
We are transitioning into the silent threat of patient care, pressure injuries. The clinical texts dedicate an enormous amount of time to this pathology because they are largely preventable, yet incredibly destructive.
The risk factors for developing a pressure injury form a perfect storm of biological vulnerabilities. Immobility is the foundational trigger. If the skeletal structure cannot move, the skin takes the damage.
But immobility is heavily compounded by impaired sensory perception. If a patient is paralyzed or comatose, their brain never receives the pain signals screaming that a specific patch of skin is suffocating.
Add in malnourishment, aging skin, fever which increases metabolic demand, and the constant friction of medical devices, like oxygen tubing or catheters, pressing into the skin.
And to truly comprehend how these injuries form, the texts require us to analyze the exact physics of the damage. They differentiate between three distinct mechanical forces: pressure, friction, and shearing.
Let's break those down. Pressure is the most direct force. It is the perpendicular weight of a heavy bone, like the heel or the tailbone, pressing the skin down against the mattress.
If that physical pressure exceeds the capillary closing pressure, which is the force the heart uses to pump blood into those tiny superficial vessels, the vessels collapse.
The blood flow stops entirely, the cells are starved of oxygen, and the tissue begins to die within hours.
If pressure is a crushing force, friction is an abrasive force. Friction is the mechanical stripping of the epidermal layer caused by the skin dragging across coarse surfaces.
Like pulling a patient across stiff bed linens.
It removes the outer protective barrier, leaving the dermis exposed to bacteria and moisture.
But the force that the materials highlight as the most insidious is shearing. If friction is dragging sandpaper across the surface, shearing is like a tectonic earthquake happening deep underground.
The tectonic analogy captures the mechanics perfectly. Shearing damage occurs invisibly deep beneath the skin.
Imagine a patient whose head of the bed is propped up.
Over time, gravity pulls their heavy skeletal structure downward. However, the outer layer of their skin is slightly moist, or there is friction against the sheets, so the skin stays perfectly glued in place.
The epidermis does not move, but the heavy bones and the deep muscle tissue slide downward. The delicate vertical blood vessels that connect the deep tissue to the surface skin are violently stretched and brutally torn apart.
It shears the vascular supply entirely. This creates a massive zone of necrosis, dead tissue deep near the bone, while the surface skin looks completely normal.
By the time a shear injury finally breaks open at the surface, there is already a catastrophic crater of dead tissue underneath.
Because the damage can be invisible, early detection is the paramount goal for the nursing staff. The slide deck highlights a crucial, simple diagnostic tool, the blanchable test.
If a nurse rolls a patient over and sees a red spot over a bony prominence, they press their finger firmly into the center of the redness.
If the skin turns white when pressed and then rapidly turns red again when the finger is removed, the tissue is blanchable.
This indicates that while the area is irritated and hyperanemia is occurring, extra blood rushing to the site, the microvascular structure is still intact. The blood can still flow in and out.
It's a warning sign, but the tissue is alive.
However, if the nurse presses their finger into that red spot and it is non-blanchable, meaning the redness stubbornly remains an angry dark red or purple, no matter how hard they press the klaxon sounds.
Non-blanchable erythema means the tiny capillaries have been crushed for so long that the blood has coagulated. Microvascular thrombosis has occurred. The damage is permanent, and a stage 1 pressure ulcer has officially formed.
Once that damage begins, the prevention protocols escalate aggressively to mitigate the physics we just discussed. Hospitals mandate keeping linens perfectly tight and wrinkle-free to eliminate friction points.
They implement rigid turning schedules, repositioning the patient entirely every 1 to 2 hours to relieve the perpendicular pressure.
They also enforce strict rules about the angle of the bed. The head of the bed must be kept below 30 degrees whenever possible to prevent gravity from initiating that deep tectonic shearing.
They use pillows or specialized foam boots to physically float the patient's heels completely off the mattress because the heel bone is incredibly sharp and the tissue covering it is razor thin.
And crucially, nurses are trained to lift patients using draw sheets rather than dragging them again to neutralize shear forces.
The slides also include a very specific prohibition. Do not use generic powders or cornstarch to manage moisture on the skin.
While they absorb sweat initially, they quickly clump together, forming an abrasive, gritty paste that drastically increases friction and tears the fragile epidermis.
To manage this immense logistical challenge, the care team does not simply guess which patients might be at risk. They rely on a validated predictive algorithm called the Braden scale.
The Braden scale assigns a numerical score based on a patient's deficit in 6 specific categories: sensory perception, moisture, activity, mobility, nutrition, and friction shear.
A perfect score is 23, indicating 0 risk. The patient can feel pain, walk, eat perfectly, and control their bodily fluids. But as deficits compound, the score drops.
If a patient's Braden score falls to 9 or below, they are classified as very high risk. This triggers an immediate massive deployment of resources.
The clinical texts provide 2 practice scenarios to demonstrate exactly how the Braden scale dictates the level of nursing intervention.
Scenario 1 introduces us to Mr. Jameson. He is 72 years old, one day post-op after abdominal surgery. He is alert, though drowsy from medication. He requires moderate assistance to turn in bed.
He is experiencing hot flashes and is sweating heavily. He is only eating about half of his provided meals.
Crucially, he has no red spots on his skin yet, but the nurse notes he tends to slide slightly downward when the bed is raised.
Assessing Mr. Jameson through the Braden scale reveals a mild to moderate risk. His score would likely land around 13 or 14.
His sensory perception is intact, he can feel discomfort, he possesses some baseline mobility.
However, his age, his reduced caloric intake, and the constant moisture from his sweating are significant vulnerabilities. The sliding introduces a mild shear risk.
The nursing intervention here is proactive but standard. Ensure he is turned every 2 hours, apply heel protection, heavily encourage him to eat his protein, and aggressively manage the room temperature and his clothing to keep his skin dry.
Now we contrast that with scenario 2. Mrs. Daniels. She is 58 years old, hospitalized after suffering a severe massive stroke. She is lethargic, responding only to deep, painful stimuli.
She is completely incontinent of both urine and stool. She is entirely bedfast, unable to initiate even the slightest movement without total assistance from the staff. She is taking in almost zero nutrition.
The nurse notes she is constantly sliding down in the bed due to gravity, and her sacrum, the bone right above the tailbone, is already displaying non-blanchable redness.
Mrs. Daniels represents the absolute extreme of the Braden scale. She is the clinical definition of a very high-risk patient, likely scoring an 8 or a 9. The compounding physics are devastating.
Her sensory alarm system is disconnected. She cannot feel the tissue dying. She is completely immobile, meaning the perpendicular pressure is constant.
She is constantly soaking in highly acidic moisture from incontinence, which rapidly dissolves the epidermis. She has no protein intake to rebuild cellular damage, and she is actively experiencing severe shearing forces as she slides.
And the non-blanchable redness proves the microvascular damage has already triggered. The collapse is underway.
For Mrs. Daniels, the standard protocol is insufficient. Turning her every 2 hours will not save her tissue. She requires aggressive, mandatory repositioning every single hour.
She must be placed on advanced, dynamic support surfaces, specialty computerized air mattresses that constantly inflate and deflate different zones to shift the pressure burden automatically.
She requires immediate application of thick barrier creams to shield her skin from the acidic moisture, and her care absolutely mandates a consultation with a specialized wound, ostomy, and continence nurse.
If the care team misses even a single shift of this aggressive hourly protocol, the red spot on her sacrum will inevitably disintegrate into a catastrophic deep tissue crater exposing the bone.
It transforms patient care into a high-stakes hourly battle against gravity, chemistry, and time. It really crystallizes the immense pressure the nursing staff operates under.
It absolutely does.
Well, we have covered a phenomenal amount of biological ground today. We started at the microscopic layers of the epidermal shield, mapped the chaotic, highly organized vascular battlefield of the inflammatory and proliferative healing phases,
And examined the absolute necessity of intense nutritional support and precise mechanical debridement to supply the cellular construction crew.
We finished by exploring the silent, deadly physics of pressure, friction, and shear, and how the Braden scale attempts to predict the breakdown of the human form before it happens.
The knowledge embedded in these clinical nursing materials extends far beyond the walls of a hospital intensive care unit. The mechanics of tissue preservation and repair dictate how we interact with our own biology every single day.
Whether you are stepping into a caregiving role for an aging parent and now deeply understand why keeping their skin perfectly dry and turning them in bed is quite literally a matter of life and death, or you are recovering from a minor outpatient surgery yourself, or you just finally grasped the molecular reason why drinking water and eating a protein-heavy meal helps a scraped knee heal faster. This deep dive empowers you. You are now equipped to work in tandem with your biology, rather than fighting against it. The biological spacesuit you wear is no longer a mystery.
Beautifully said.
But as we close, I want to leave you with a final lingering thought. It is an evolutionary question that wasn't directly answered in the clinical texts, but that this entire exploration points toward. We have detailed the body's incredible, highly choreographed, almost magical ability to completely rebuild complex vascular networks and tissue from the inside out. The logistics are flawless. So why does the end result of a severe wound so often look like a messy, disorganized patch job?
It's a great question.
Why does our biological programming prioritize building thick, tight, misaligned scar tissue instead of simply taking the time to perfectly replicate the original, flawless, elastic skin? Is the existence of scar tissue an ancient evolutionary trade-off? Did our biology decide hundreds of thousands of years ago on the savannah to sacrifice cosmetic perfection and complex hair follicles for absolute blistering speed? Was the biological mandate simply to close the breach fast enough so our ancestors wouldn't succumb to a fatal infection from a simple animal scratch? The next time you look down at a faded scar on your knee or an old surgical mark on your arm, realize you aren't just looking at the remnants of an old injury. You're looking at a brilliant, desperate biological compromise made by your body, millions of years in the making, designed specifically to keep you alive. Thank you so much for joining us on this deep dive into the fascinating, resilient world of human tissue and repair. Stay curious, and we will catch you on the next deep dive.